Good evening, everybody. A warm welcome to this very interesting webinar organized by Indian Chess Society, which is going to be on oxygen therapy from A to Z. So, this is a very, very basic topic, but it's the most interesting topic and the most important topic for us pulmonologists. And very often we take many things for granted because we've forgotten a lot of our physiology. So, it is going to be a beautiful revision of everything that we might have forgotten, which is to improve our practice. And most importantly, we'll also come to know new things which are happening in the way we can give oxygen to the patients, including the HFNO. I'm very, very happy and proud to let you all know that today's webinar has one of the best combination of faculties till we've had till date. Each and every faculty is extremely accomplished, extremely intelligent, and is doing fantastic work. I would like to first introduce our moderator, none other than Dr. S.K. Chhabra, who needs no introduction whatsoever. He is one of the most popular and most respected pulmonologists who all of us would love to reach out to if we were stuck with a case. Of course, he's got a great introduction to really talk about. He is currently the head of Department of Pulmonary Sleep and Critical Care Medicine for Specialty Hospital, Delhi. He has been the former director professor at the Department of Pulmonary Medicine at the famous VP Chest Institute, University of Delhi, former head also of Faculty of Medical Services. He's the editor of India Journal of Chest Diseases and Allied Sciences. He's associate editor, section editor. He's many research interests. He had more than dozen research projects going on right now, including with the WHO, with the ICMR, DST, and CSIR. He's got 172 publications, and he belongs to the elite group of top 2% pulmonologists in the world. He's listed that way. So, with this brief introduction, which I still don't think I've done justice to Dr. Chhabra, I would like to invite Dr. Chhabra to please take over. Over to you, sir.
Thank you, Dr. Nene, for inviting me to moderate this important session. It's a topic which is very close to my heart. Lots of people ask what's there to discuss in oxygen therapy. It's so simple. In fact, it's very often left to the paramedical staff or to the respiratory therapists. But it is also one of the treatment modalities which is very often misused and abused. So it is very important that we clear our fundamentals, how to use oxygen, what are the devices available, what is the mechanism of hypoxemia, and how do we manage with different kind of devices, where to use which kind of devices. So there's a whole lot to discuss. Now, oxygen, as we know, is the most abundant element on Earth. About 45% of Earth crust is oxygen. And what to say of human body? 65% of our mass is oxygen. So we are all oxygen. Yet, while we are made of oxygen, we are living in oxygen, yet there are times when we don't get enough oxygen, and that is where oxygen therapy is required. The human body has a very complex mechanism, and it's an amazing method by which oxygen reaches our tissues. We are sitting in an atmosphere where there's 21% oxygen, and oxygen has to reach my tissues, let's say the tip of my finger. So it's not that it will simply diffuse. It's a whole lot of complex process. The brain has to generate the respiratory drive. My respiratory muscles have to respond. The lung mechanics has to be good. The oxygen must diffuse across the alveolar-capillary membrane into the pulmonary circulation. That must take it to the heart, and heart must then distribute in the right way to the tissues. It's a complex distribution system, and things can go wrong anywhere. That is where we step in as pulmonologists with our therapy, oxygen therapy, and there are different devices. So we have got an exciting discussion coming up, and leading this will be our speaker for the day, Dr. Khusrav, who will be giving a brief talk to set the ball rolling, give a bird's eye view of what is going to follow subsequently. And I've got a brilliant panel, which is a mix of experience and young bubbling pulmonologists, the future of tomorrow. So looking forward to a very exciting session. I invite Dr. Khusrav. Dr. Khusrav Bajan is HOD of Emergency Medicine and Critical Care Consultant at PD Hinduja National Institute and MRC. He is a gold medalist, first certificate course held by the ISCCM in 1999. And he's a chief of the relief team. If I go through his honors and achievements, then that will take a lot of time. But all I can say is he's one of the best and most qualified persons to talk about this topic. He has received many awards, and surely he's the one who is going to do justice to this topic today. So I invite Dr. Khusrav Bajan to start with his presentation, and then we'll follow up with the panel discussion. Dr. Bajan.
Yeah. Thank you, Dr. Chhabra, for that very nice introduction to the topic and to me. And I thank the Indian Chest Society and Dr. Amita, who is a very dear friend and an amazing pulmonologist, for having me over for the third time, I think. And I'm very, very excited because this topic is close to my heart. And as Dr. Chhabra said, that it is very, very unfortunate that as you go up the rank and you become senior, you don't want to talk about the lowly oxygen therapy. You want to talk about ECMOs and whatnot. So oxygen therapy is often forgotten. And that's why I think it's a very, very good topic that Dr. Amita has chosen. And Dr. Chhabra gave you a very good insight about how oxygen is there in the body and how much do you need and how does it reach the tissues. And there is a lot of difference between the arterial oxygen and the tissue oxygen. So I will start my presentation with my, if I'm allowed to, is it visible?
Khusrav, before you start, I just want to tell everybody that, it's going to be a delight listening to Dr. Khusrav. When I was doing my ICU training in 1998, he was a consultant there. He's actually taught me, and he's a fantastic intensivist, a great speaker. I'm very, very happy that in addition to Dr. Khusrav and Dr. Chhabra, we have the most fascinating panel today, who, of course, Dr. Chhabra will be introducing. But I'm most grateful to my dear friend Nitin, who's one of the best pulmonologists I know, and an amazingly, equally great human being who's always been there for me. So Nitin, thank you for being on board. I'm so grateful to Dr. Chandrakant Tarke, who's doing fabulous work in Hyderabad, a brilliant pulmonologist who makes us so proud, who loves to keep a low profile, but is doing genuinely great work. So thank you, Dr. Chandrakant, for being here.
You,
of course, you all will be introduced properly by sir, but I just want to be grateful to you all. I'm so grateful to Ambika. Dr. Ambika Sharma does fantastic work in Jaipur, always smiles, keeps the lowest profile, but she is somebody who really knows her stuff well. And she is somebody who we are extremely proud of. And of course, Dr. Alisha, who has the distinction of being really a pulmonary intensivist. Like basically critical care is actually in her blood. She's doing fabulous work. It is really her love, the pulmonary critical care. And she also keeps a low profile, but is doing fabulous work. So I just want to be very, very grateful to all six of you all for being on board. Of course, I'm so thankful to entire Governing Council of Indian Chest Society for this initiative. A huge big thank you to CIPLA for being our academic partners, especially Vipul, Mr. Vipul Ranjan, without who this would not have been possible. We have more than 1,800 registrations and about almost 1,500 logins already. And a big thank you to Bijal also, who's in our tech team. So with this, I'm sorry for interrupting, but now you may start, Khusrav. Thank you.
Yeah, thank you so much, Amita. And yes, Dr. Nitin was my senior at Sion as well. So I'm so amused to be today. Now, without much ado, my slides are seen, right, properly?
Yes.
Okay. So basically, I'm going to cover on oxygen therapy. I'll take about 25 to 30 minutes max. And we have given the webinar a name A to Z. So I will tell you everything that I know about oxygen therapy. But before that, I have labeled it as less is more. And I would say that only give oxygen when it is needed, because now there is enough evidence that is coming up in the recent decade that giving extra oxygen is probably deleterious and increases the mortality. So let us first understand a little on the physiology, and then only will we be able to understand how oxygen therapy, how to place oxygen therapy in today's day and age, in the ICU, in the hospital, and probably even at home. But I will mainly be talking about the sick intensive care patient. So they say the best is love, but I think oxygen is more important than love. And in this class, I have the topic less is more, and there are only two people, but here I hear that we have highest registrations. So it doesn't matter what the turnout is. It does matter, but it is very important how many of us gain from today's seminar. And I won't stand too much in between the oxygen therapy talk and the amazing panel discussion that will follow this. So oxygen was discovered by J.B. Priestley in 1773 when he was trying to ignite the mercury. And he said the feeling of it to my lungs was not sensibly different from that of common air, etc. I won't read into this, but we should know when oxygen was discovered. There are some terminologies which we should know when we talk of fraction of inspired oxygen and what three factors are responsible for the FiO2. We will come to that in a bit. Then comes another terminology called as the PiO2, which is partial pressure of oxygen in atmosphere. And this PiO2, sorry to put you through a lot of algorithms here, but we must know as pulmonologists and intensivists what we are talking about, where we are talking about the oxygen in the body and in the atmosphere. So PiO2 is nothing but the FiO2, which is 0.21 into the atmospheric pressure, which is 760, minus the water vapor pressure, which is 47. So our PiO2 is actually 150. Now we know about FiO2, what we breathe in. We are talking about PiO2, which is 150. The alveolar arterial gradient is nothing but the alveolar oxygen minus the arterial oxygen. And this is nothing again but the PiO2 minus PaCO2 upon respiratory quotient. And therefore, it's 150 minus 40 upon 0.8, which comes to 100. So our alveolar pressure is of oxygen is about 100. And then if you can't remember all these formulas, there is a very easy formula for PaO2, which is age dependent. So you have a 50-year-old or 60-year-old, then 60 plus 10. Let's keep it simple. A 70-year-old person plus 10 upon 4 would be a gradient of 20. So normally our gradient is just about 5 or 10, but as age advances, the gradient increases. So this is important because we need to understand what is the reason for the oxygen deficit in the body. And this is just to explain the same thing, alveolar gas equation, which is PO2 150 minus this, and it depends upon the carbon dioxide and the respiratory quotient, and that is dependent upon fat, proteins, carbohydrates, and the respiratory quotient is different for each. What is important is if the CO2 increases, the PaO2 will decrease, and obviously if the alveolar oxygen decreases, then the arterial oxygen will also decrease. Just one more line about the AaO2 difference. As I said, it is about 5 to 10, but this is the diagram which actually tells you age plus 10 upon 4. So in the atmosphere, we have 150 millimeters. Then in the alveolar gas, we have 99 or 100. In the arterial, we have about 92. In the tissues, we have 33. And in the mitochondria, we have only 5. So it all depends upon what is the need of every tissue and organ in the body. We cannot talk about oxygen without talking about the S-shaped oxygen dissociation curve. We know that 60 of PaO2, after that there is a linear association, but we must also know that there is a right and left shift, and in acidosis there is a right shift, so there is decreased affinity and therefore oxygen is given off left easier. Whereas in the leftward shift, where there is carbon monoxide poisoning, there is an increase in the affinity and the oxygen cannot be released to the tissues easily. So this is very important again to understand what is your oxygen dissociation curve rather than looking at only one parameter. I hope I'm not confusing you all because just trying to make it simple. Now, a little maths again because we need to understand what oxygen goes to the tissues. So 1 gram of hemoglobin binds to 1.34 ml of oxygen. We know that hemoglobin, oxygen saturation, and carbon dioxide put together is responsible for the delivery of oxygen. And by a complex formula, you should remember that 20 ml of oxygen is contained in 100 ml of blood. So basically, 1/5 of your blood volume is oxygen. and therefore our delivery of oxygen is 1 liter, whereas our cardiac output or the entire blood volume is 5 liters. So on an average, if you can't remember these formulas, think of oxygen as 1/5 the blood volume. Also, this delivery to the tissues of oxygen depends upon 3 fundamental factors which are responsible for hypoxia. The biggest is cardiac output, then comes hemoglobin, and then comes the oxygen saturation. So hypoxemic hypoxia is not the biggest criteria, but in our practice, we see it very often. And then this delivery of 1000 ml goes to the tissues, but the tissues only are happy with 250 ml, and therefore they extract 25%, and on the venous side, 75% is returned back to the heart. So therefore, your arterial saturation is near 100%, but your venous saturation would be 75%. So just to understand what happens at the tissue level. This brings me to the next terminology. I promise in 2 slides, I'll finish the physiology. Hypoxemia versus hypoxia. And we know whenever we talk about emia, like any surname, emia is blood, and therefore deficiency of oxygen in blood is hypoxemia, whereas hypoxia is the deficiency of oxygen in the tissues. Therefore, tissue hypoxia is mainly of 4 types. There is a 5th type I will come to, which is hypoxemic, anemic, circulatory, which are dependent on the delivery. We told you 3 factors. And then you might take the horse to the well, but it can't drink it. So you might push the oxygen to the tissues. The tissues are histotoxic, like in sepsis. And here the patient will not get the oxygen because they are not taking up the oxygen. So this is a graph which tells you about the 4 causes. And the 5th one is an affinity, which is the oxygen dissociation curve. And I'm not going into more details of this. Whenever, I promise you last slide on this. So the PaO2, when it is less than 60, we call it hypoxemia. We need to put all that I discussed together. If the gradient is normal, then it is hypoventilation and reduced FiO2, which is high altitude. But if it is a high gradient, then it is dead space or shunt. In shunt, it could be physiological or anatomical. And in the anatomical shunt, even giving oxygen will not correct the deficit. So there are various reasons, of which only 3 reasons, anatomical, physiological shunt, and dead space, would lead to a high alveolar arterial gradient oxygen difference. Now coming to my talk, when we talk about respiratory support, I have just made a mnemonic here, on me. On me would contain oxygen, NIV or HFNO, mechanical ventilation, and then ECMO, and none of it can go without proning. So we are talking about a whole gamut of things we do for a patient in respiratory failure with hypoxemia and with CO2 retention. So as Sir rightly mentioned, oxygen is the 3rd most abundant atom in the universe. It is the 2nd most abundant atom in the biosphere, and it is the most abundant atom on the Earth's crust. What is unfortunate is that it is also the most abundantly used drug in the critical care unit and in the ER. Yes, we know that oxygen has a lot of good factors, and getting more oxygen might help in relieving headaches, and therefore hyperbaric oxygen is used by celebrities to get a better skin and other things, but we are not talking about that aspect of oxygen. So oxygen is, unfortunately, as I said, the commonest site in the ICU. Patient comes in breathless. We do not even bother about the saturation. We give them oxygen and we give them IV fluids. That is unfortunate. Why giving oxygen here is dangerous is that if they are maintaining a saturation of 94 and give them oxygen, now you are masking the problem and the saturations might come up to 98. But if you have not given them oxygen and patient deteriorates, you would know on the saturations that they have also started dropping, and you would understand the severity of the illness and not just mask it. This is just one reason why only oxygen therapy should not be used as a knee-jerk reflex. Remember, my friends, oxygen is a drug, and whenever we talk of drug, we talk about side effects as well. And therefore, we must use it rationally, we must not abuse it, and we must keep in mind the toxicities. Now, one more aspect we have to understand what FiO2, because without this, you will not understand any oxygen delivery system. So what is FiO2? FiO2 is the fraction of inspired oxygen at the mouth. This depends upon three factors. Obviously, the amount of oxygen I'm giving. So the flow rate, is it 2 liters or 15 liters, which is the maximum on any cylinder or any wall-mounted oxygen. Then the reservoir size. So if we don't have oxygen masks or nasal cannula, our own reservoir is the paranasal sinuses, which is 50 ml. And then the third would be the mechanical ventilation, minute ventilation. I'm so sorry. So minute ventilation is also decides the FiO2. So if you can remember this, you will understand what I will teach in the next few, or discuss rather than teach in the next few slides about the oxygen delivery systems. So again, to remember, FiO2 depends upon not only the flow rate, but also the reservoir bag. And therefore, the NRBM that we use, it gives you more oxygen because it has a reservoir bag. And then the minute ventilation of the patient. Slower the ventilation, more the oxygen, ambient air will mix with the oxygen and it will affect the FiO2. Faster the minute ventilation, the patient will have lesser time for the ambient oxygen and therefore the FiO2 changes. So these three parameters we must always remember. This is what I just discussed. So what is oxygen therapy? By definition, administration of oxygen at a concentration greater than what is available in the ambient air, and that is 0.21 is the FiO2. So anything above that is oxygen therapy when given to the patient. And very nice cartoon here. Obviously, it's not a man, but you have a cylinder along with that. Now, please, if you don't want to take anything that I am going to talk today, but take only one message home, this is the slide you must definitely understand. Oxygen delivery is divided into low flow and high flow. Now, please, I said it again, the amount of oxygen that you are giving by the cylinder does not decide low flow or high flow. We are not talking of low concentration or high concentration. We are talking of low flow versus high flow. Now, everyone has an inspiratory flow rate of 30 liters per minute. When the person is extremely tachypnic, it may even go to 40 or 60 liters per minute. The maximum oxygen that you give is 15 liters per minute. When this oxygen is less than the patient's inspiratory flow rate, am I making sense? When the oxygen delivered is less than the inspiratory flow rate, obviously ambient air will mix and therefore the FiO2 that you may dial will be variable. So please understand, a low flow system is a system in which an FiO2 is variable, and the reason for this is the FiO2 that you are delivering at the mouth or the oxygen concentration is less than the flow rate. Oxygen flow rate is less than the patient's inspiratory flow rate. As against that, now to convert that 15 liters, I will use a phenomena called the Bernoulli. I will come to that in a bit, and that will convert the flow at the mouth to be higher than the patient's inspiratory flow rate. Once I do that, whatever the patient takes in is only going to be pure oxygen, which we have set. And this is called as a high flow rate. And therefore, the FiO2 delivered to this person is constant. If I'm clear about this, I can move on. And now I'm going to ask you about the differences between the low flow system. So every system that we use, we have to ask a question, is it low or high flow system? So obviously the nasal cannula, face mask are low flow systems, and everyone, if I would ask initially, would say that NRBM is a high flow. But as I said, NRBM may give you 100% oxygen, maybe at a high flow rate, but it is a oxygen flow rate and it is not higher than the patient's inspiratory, and therefore the minute ventilation and other things will vary the FiO2 and it does not give a constant FiO2. As against that, if you're using a Venturi mask, that's the only technique which gives you a high flow system. And then there are some other exotic ones like Oxy mask and HFNO, which I might just touch upon. So in the low flow systems, FiO2 is inversely proportional to the patient's minute ventilation, as I explained, and vice versa. And if mechanical ventilation doubles, the FiO2 delivered is half, because of the mixture of the air along with the FiO2. The very first is nasal prongs, and here the reservoir is about 50 ml plus your nasal air spaces, which is another 50, which is only 1/3 your anatomical dead space. And here you cannot give more than 6 liters. Otherwise, it is very claustrophobic and it dries up the nasal passage. So when you give 1 to 6 liters per minute, you are giving an FiO2 only of 0.28 to 0.44. Advantages are that it is easy to use, well tolerated. You can eat and talk simultaneously. So it is given for the less severe patient. But the disadvantage is that it can probably block the nasal passages and may even cause gastric rupture if you give more than 6 liters very aggressively. Then it brings me to the face mask, and this is important. The flow rate here is 5 to 10. Many a times patients feel that face mask is good or nasal cannula is not good. It irritates the nose. So they put them on face mask and they keep 2 liters per minute, which is extremely wrong, because what happens is when the patient inhales, he gets ambient air plus the oxygen. But when they exhale, the carbon dioxide gets trapped within the mask, and that when next breath is taken will go in. So there will be a rebreathing phenomena. And to avoid this, you need the minimum flow rate to be 5. So please remember, nasal cannula is 1 to 5 and flow rates on a face mask would be 5 to 10, never less than 5. Otherwise, you're doing more harm. Here, the reservoir is a little more and it is 100 to 200 mils per capacity. And the maximum FiO2 it might give would be 0.5 or 0.6. So this is about the nasal mask, face mask and the nasal cannula. Advantages are you can give more FiO2 and that comes to almost 0.6. Disadvantages, as I mentioned, if you don't keep the flow rates proper, there could be carbon dioxide retention and you will probably need more and more oxygen. We know that oxygen was an absolute scarcity during the COVID times and therefore you must use it sensibly. Now we are talking of the reservoir bags when we are delivering oxygen. So there is a reservoir bag capacity of 600 to 1000 ml. And therefore, because of the reservoir bag, as I told you, FiO2 depends upon that as one part of the 3. It delivers higher than 0.6 FiO2. So whenever the oxygen need is more, we would think of a reservoir bag oxygen. There is a partial rebreathing, but I have never seen it and we don't use it. So I will go straight to the NRBM or the non-rebreathing mask. Now this mask has a one-way inlet and therefore an reservoir bag. So it can even give you oxygen at 15 liters of oxygen, can give you up to 100%, but depends upon the minute ventilation of the patient, excuse me. So this is a non-rebreathing mask. When there is a one-way flap here and there is a one-way valve here, what happens is oxygen will come in from this line, from the tubings, go up and also go down and fill the bag. So now the bag is filled with 100% oxygen. This is the reservoir bag. And oxygen goes to the patient. The next inhalation that patient does, the inhalation will be taking a little oxygen from here and full oxygen from the reservoir bag. And therefore, it can go up to 100% of FiO2 or 0.1 FiO2. When the patient exhales, this one-way valve will allow the oxygen to escape, carbon dioxide to escape from the sides here and not go into the bag. So the bag will still contain 100% oxygen. And therefore, NRBM is a high oxygen concentration, high FiO2 delivering technique, but it is still a low flow system and I can't overemphasize on that. Advantages, there are high FiO2s that you can get, and disadvantages, you need a little tighter fitting. Otherwise, all this is a waste and therefore cannot be used along with a RT insertion and you cannot give nebulizers to this patient. Coming to the high flow system, here I said that the oxygen delivered at the mouth level, the flow rate is higher than the patient's inspiratory flow rate, which might vary between 30 to 60 liters per minute. And here, therefore, the FiO2 is constant. It doesn't give more oxygen, but it gives you a constant oxygen of FiO2. And here it can again give you only from 24 to 60%. And this is the only thing that gives you high flow system, that is the Venturi mask, which depends upon the Bernoulli phenomena. So this is the mask. You have oxygen coming in, you have pores at the side, and you would have ambient air coming in. So what happens is they make a hole here, a very tiny hole, and the oxygen that comes in comes through a small hole, and therefore there is a huge jet stream. This huge jet stream will also, depending upon the size of the holes, get a viscous drag. So there is a jet stream coming from a hole. There are side ports from which air gets into a viscous drag, and the patient then gets an FiO2. Smaller the hole, more the jet stream, and smaller the side holes, lesser air can come in. So therefore, those Venturi masks which give you more and more FiO2 have smaller holes here and here. So the advantage here is the FiO2 is constant. And one technique that we say in COPD, many will disagree with me, but there is logic here. Please hear me out. In COPD, we must always have low oxygen. That is also a controversial topic, but fine. It might reduce the respiratory drive. So we must not give more oxygen, and we must give only a constant 1 or 2 liters of nasal cannula. And it's been a practice, 95% of us doctors follow, that a COPD gets 1 to 2 liters of oxygen by nasal cannula. Now the problem here is they are slow breathers, mechanical minute ventilation is low, and therefore they will not get 2 liters, but they may get actually 4 to 5 liters here, because it is one of the things which decide your FiO2. So remember that in COPDs, giving 1 or 2 liters may not be a good idea, but actually putting them on Venturi mask and giving only 24%, which is as good as 1 liter, at least here the FiO2 is constant. I know many of the panelists and even sir might disagree, but this is the logic behind it. And old habits die hard. So I would request that if this is physiological and logical, we must do it even in COPDs. And these are the nasal cannulas, the mask, the non-rebreathing, and these are the 2 Venturi masks. Here you may have one technique where you can see the side ports and the holes. And here you can again dial this in just one parameter, and then you can decide phenomena. Smaller the hole, more the viscous drag, more the jet stream, smaller the side ports, less the viscous drag, and therefore FiO2 can be tailored and given constantly. If we have understood this, we've understood 90% of our oxygen delivery systems. But then there are some exotic ones and exclusive ones like the oxy mask, and then the HFNO, and one slide on hyperbaric. So what is this oxy mask? When it came about, I said, no, it doesn't fall into low or high flow. And if I don't understand it, I'm not going to use it. And it's got so many holes that I don't even know if the patient really gets the oxygen properly. But trust me, in the last 5 years, I've realized that oxymask is an amazing technology. I'm not from the company again, but it has very good technology. So it is open. You have lots of holes, so you can even drink and talk through it. And it does not have to have a tight fitting mask. So how does it give you oxygen across the board, across the spectrum, from as low as 24 to as high as 90 or 100% as compared to a even non-rebreathing mask? So what has happened so far is patient has a little desaturation. I'll put him on 1 or 2 liters nasal cannula. Gets worse, I put a mask. Gets worse, I may put a Venturi mask. Gets worse, I put a non-rebreathing. And gets worse, maybe he'll die, he or she will die, or I might get a chance for NIV or HFNO or even intubation. But if you use an oxy mask, I'm not propelling to making you all no compulsion to use it, but I'll just explain what it does. It gives you an FiO2 of 24 to 90%. And how does it do that? So it basically uses the technology called as the mushroom phenomena. As you can see in this, this is the pin or the mushroom, and there will be this oxygen which comes through this port, and this is an umbrella or a mushroom. So when the oxygen comes in and this port is closed, so when oxygen comes in from this, it goes in from this end and it goes in from this end because this is blocked, and it hits under the umbrella or the mushroom and then gives a big jet stream just at the nose. So it's a tiny mushroom which gives you a huge jet stream at the nose. So this gives you a constant FiO2 and it gives you an FiO2 depending upon the oxygen concentration that you are, flow rate that you have set. So mushroom phenomena or umbrella phenomena in an oxy mask is pretty useful, and it is very, very non-claustrophobic because it can be used with lots of holes. You can even have a straw and have a milkshake or some water. So this is exactly how it works. Oxygen goes in from the sides and it causes a severe jet stream right at the nose level. So it has to be fitted just so that the mushroom is at the nose and mouth level. Now we come to HFNO, and I'm not going to talk too much about it, but just that during the COVID times, it really changed the picture and it was given the name of super oxygen, and the company that makes it is Airvo 1 and Airvo 2. What it does is high flow oxygen therapy flushes the dead space, supports inspiration, and also humidifies. So there's a humidifier and it works on the high flow principle. So the high flow is important for something and the high oxygen is important for something, and I'll come to that in a bit. So the high flow actually in the inspiration improves the FiO2, and in the expiration it will have a small PEEP effect. And this will again improve the oxygenation and it will wash out the dead space. So basically it decreases the work of breathing, improves the PO2 and washes out the CO2. Therefore, HFNO is also considered a replacement, if done properly, to a NIV or a CPAP device. Now, what you need is two things. You need an oxygen blender and you need a humidifier, and FiO2 can be delivered from 21 to 100%. So this is how it looks. There is a single tubing, and this is what goes into the patient's nasal areas or cavities, nostrils, and this is the tubing. So it's almost looking like a nasal pillow that we may use in NIV. Now it goes from here. There is a humidifier attached, and then it can be attached to the patient through these prongs or devices. So what does an HFNO do? It is an FiO2 which will be targeted to the PaO2 of the patient. Lower the PaO2, we will set it to 60, 80 and maybe more. And the work of breathing is the target towards the flow. So if the work of breathing is high, the CO2 is high, I might increase the flow. If the CO2 is normal and the work of breathing is okay, I might even use 40 or 30 liters per minute of flow. So usually we start off with 60 FiO2 or 0.6 FiO2 and 60 liters of flow for the work of breathing, and then we can titrate it up or down. Coming to the next part, home oxygen, I'm not going to talk about it, but that also can be divided into 4 categories: cylinders, concentrators, liquid oxygen, and then membrane separators. And that's where I would stop talking about home oxygen because it's a different, LTOT is a different thing altogether. What is hyperbaric oxygen? When you are giving 1 atmosphere is what we breathe at, but 3 atmospheres or 2 atmospheres and above if you use, then you are giving much more oxygen to the tissues. And one main indication is carbon monoxide poisoning. So at sea level, we get a plasma oxygen concentration of 3 ml per liter. Don't ask me how we got that. Tissues at rest require 60 ml of oxygen per liter. And at a pressure of 3 atmospheres, we are actually giving 60 ml per liter of plasma, of oxygen to the plasma. And therefore, it gives so much oxygen that it does not depend on the oxygen dissociation curve. And if the oxygen is bound to the hemoglobin in a wrong way, like carbon monoxide poisoning, etc., or methemoglobinemia, it still can improve the condition by giving oxygen. So therefore, hyperbaric can be used for wound healing, primary treatment for decompression or air embolisms, carbon monoxide poisoning, or smoke inhalations. it can be used for not proven, but some sensory losses and intracranial abscesses, and in certain oncologies and cellulitis and gas gangrenes. So here are the main indications like carbon monoxide poisoning, necrotizing fasciitis, and arterial air embolism, where you might use hyperbaric oxygen. So I tried to cover every form of oxygen that is available. Now the last part here is high altitude. This depends upon the Boyle's law. And if you know, our Mount Everest is the highest peak, but here as an altitude of 10,000 meters, we are not talking about feet, the atmospheric pressure is only 200 millimeters instead of 760 at sea level. And therefore, there is 21% of oxygen there, but the partial pressure of oxygen will be only 32. And here you can decide that the air will have 0.21 of oxygen, but the atmospheric pressure is only 200, and therefore the alveolar pressure will be 32 instead of 100. And therefore, obviously, the oxygen going to the patient will be much, much less at a high altitude. And this is just to know the four main peaks. Mont Blanc is 4,800 meters. Kilimanjaro is about 6,000. Aconcagua, I cannot say it, is about 7,000. And Mount Everest is nearly 9,000 meters. And there you need to understand how much oxygen you need to give. I promise to stop here, and I would say that oxygen is a drug and there is a lot of oxygen toxicity. Even if you give more than 460% of FiO2 for more than 2 days, or even for 6 hours, if you give 100%, you might have not only eyes, central seizures, muscular twitching, but it can even give you an ARDS-like picture and tracheobronchitis. And the reason for which, like ARDS, you've started giving oxygen, you don't even know whether now the patient's ARDS is better and you've given another ARDS because of too much oxygen. So where do I put oxygen in clinical practice? I would start off with oxygen therapy. I might need high flow. I might need CPAP and bi-level. And then finally, I might need ventilation. But by and large, if appropriately treated, I would probably stop between oxygen therapy, low and high flow, and then the high flow nasal cannula, which is 60 liters per minute. Is there any evidence to what I have said? Evidence can be of 4 types. Yeah, my friend told me and I got better, or Khusrav told me and I think I should use it. Or the mice got better. There is some experiments in the lab. Or my previous patient got better and therefore it's a case report. But finally, we need evidence and we need large studies. So I'm just going to give you just very few studies and I'll end here so that we have a good discussion. Why my topic I chose was less is more, because as per this oxygen ICU study, when saturations of 94 had a higher mortality than the lower oxygen saturation. ICU ROC study did not demonstrate any difference in the ventilator-free days in conservative versus usual oxygen. LOCO-2 or low carbon dioxide demonstrated no difference in 28-day mortality, again between liberal and conservative in cases of ARDS, but it did show potential harm in the conservative targets when actually seen. Then there is another study called as low or high oxygen targets in the NEGM. And here again, they realize that it doesn't make a big difference if you're using 60 as your target or 90 as a target. There is one more systematic review, and this systematic review, I will just look at this 2,900 patients of pneumonia and myocardial infarction, where low targets were kept at 60 millimeters, high targets were kept at 90, and there was a 90-day observational mortality rate was 42.9 against 42.4. So again, why waste the oxygen and why give more? And there are lots of studies which actually showed in the green and in the blue, you can see that low green means supports, evidence supports low oxygen, blue means no difference, and yellow supports high oxygen. And as you can see, the green definitely is more in the ICU. In myocardial infarction, probably no difference. And in stroke, you might land up giving higher oxygen, or it's equal with whatever oxygen you give. So in the ICU, if you look, There are 9 studies which support low oxygen, and there are 3 studies which say no oxygen difference. I mean, no mortality difference, and none of the articles support high oxygen targets. So I conclude here, this concluded that for ICU patients, it's different, and for stroke patients, it's different. And I end here by saying that oxygen is a life-saving drug and should be used appropriately and efficiently. Excuse me. And what oxygen is to the lungs, such is hope to the meaning of life. And I think we should give oxygen and a meaning of life and hope to every patient that comes across in the ICU to us. And I thank you all. I'm sorry if I've exceeded any time.
Thank you, Dr. Khusrav. I don't know whether we have got anything left to discuss.
No, sir. You'll have to hear everyone's view.
Yeah. Exhaustive review of what we're going to discuss, but it's always good to have a solid foundation at the beginning so that the panelists can take up from there and present their perspective.
Yes, sir.
So we have a lot of discussion practically covering all that Dr. Khusrav has presented. But before that, let me introduce my brilliant panel here. Dr. Khusrav has already been introduced. Now, Dr. Nitin Abhyankar, how do I introduce him? As a pulmonologist or as a poet? No, he can tell me. He's a poet pulmonologist, a rare combination. And he's as good a poet as he's a pulmonologist. And he's also giving intense challenge to surgeons. He's a brilliant thoracoscopist. He's based in Pune and a very well-known speaker. I've heard him so many times. And a very skilled pulmonologist. Then next, can we have the next slide, please? Dr. Chandrakant Tarke, he was my student at Patel Chess Institute. He did his MD, DM at Patel Chess Institute, and it has always been a pleasure to know him. And he's based in Hyderabad. He has established himself as a leading young pulmonologist of Hyderabad, and his future is bright. And he's a keen participant in conferences and so many webinars, and I've had opportunity to interact with him so many times. So it's nice to chair a session where one of my students is going to present his views. Next, please. Then Dr. Ambika Sharma is another of my students at Patel Chess Institute. She did her DTCD with us, and then she went on to do her DNB, and now she is in the faculty at SMS Medical College, Jaipur. A budding pulmonologist, growing in stature, and I'm sure she has a bright future ahead. Next, please. Next speaker. And Dr. Alisha Chaudhury, she is a consultant in Department of Critical Care and Pulmonary Medicine at SUM Ultimate Medicare Hospital, Bhubaneshwar. Good number of achievements and awards. She has also done a European Diploma in Critical Care Medicine, several best paper awards in NAPCON state conferences, and has held several professional positions. So with this brilliant panel, I'm sure we'll take forward the message that Dr. Khusrav has given to us. So let me begin with our senior most panelist, Dr. Nitin. Now, Dr. Nitin, we have all emphasized the importance of oxygen. We are surrounded by oxygen, but we can't simply absorb it from the air. So how does human body utilize oxygen, at what level, and how much do we need really?
Extremely tough question, sir. I mean, very frankly, really don't know how much do we need in the terms of, because somebody who's chronically hypoxic can get used to a very low oxygen levels and can survive much longer than expected. And somebody who gets into an acute hypoxemia can die within hours. So I think it's a very tough question, but I'll try and put it into it's largely related to the power produced during exercise. So whatever we are doing, whatever activities we are doing, it will depend. At rest, the oxygen consumption approximately will be, say, between 200 to 250 mLs per minute, or to be precise, 3.5 ml per kilogram per minute. And that's sort of, we defined it as a 1 MET or metabolic equivalent. And when we start exercising, we start walking, we start running, whatever we are doing, at a brisk walking, typically it will go to around 4 times, and it can go to 8, 10, 15, 20 times, depending on what kind of activity a person is doing. So how many minutes are we doing? So a lot of oxygen is getting inhaled. Most of it is not getting consumed. Nearly 75% is actually coming back, and therefore all we are actually consuming in the true sense of the word at the tissue level is maybe 25%, or maybe even lesser than that.
Yeah, so that is a very important point, that our oxygen requirement is not a constant but varies with our activity and efforts. And that is an important advice, especially to patients who are using at home, that they have to change their flow rates according to their activity. Otherwise, they'll become hypoxemic even with the same level of oxygen which they're using at rest if they do an exercise. So that is a very important piece of advice, that they have to change the flow rates at home depending on their activity and exercise level. So Dr. Chandrakant, Dr. Khusrav had introduced certain terms, but for the benefit of our audience, can you elaborate on certain terms and the differences: anoxia, hypoxia, hypoxemia, and respiratory failure? There's a lot of confusion, especially about respiratory failure and hypoxemia. So, briefly, can you define these terms for us?
Yes, these are the very confusing terms. To clear it, anoxia is just a complete depletion of the oxygen at the tissue level. That is called as anoxia. That is one of the form of the extreme level of hypoxia. And if it says hypoxia and hypoxemia, these are two similar, spelling wise look similar, but some difference is there. Hypoxia is a low level of oxygen at the tissue level. It's called as hypoxia. And hypoxemia is a low level of oxygen in the blood. Basically, when it is low level of oxygen in the blood, it's called as hypoxemia. And when it is a low level of oxygen in the tissue, it is called as hypoxia. And to be precise, if when there is a PaO2 below 80, it's called as hypoxemia. And coming to respiratory failure basically when the respiratory system can no longer function to keep the gas exchange at the level of the degree of metabolic needs of our body, that is inadequate gas exchange. In short, if there is a fall in arterial oxygen or increases the carbon dioxide, it is called as a respiratory failure. Basically, there are two types of respiratory failure, type 1 and type 2 predominantly. Type 1 is called as a hypoxemic respiratory failure, which is defined as a PaO2 less than 60 mm of H2O. And type 2 respiratory failure, which is defined as a hypercapnic respiratory failure, and which is cutoff is PaCO2 more than 50 mm of H2O. This is type 1 and type 2 respiratory failure.
Right. So these are important differences, especially hypoxemia and respiratory failure, because all hypoxemia is not respiratory failure. So respiratory failure has a very specific definition and a different way of management. So mild hypoxemia is not respiratory failure, but a moderate hypoxemia, that is a PaO2 of less than 60 millimeters, that comes under the definition of respiratory failure. So this distinction our residents must make. Dr. Ambika, we use several terms for oxygenation, which can be confusing for the pulmonologists and residents. We use the term saturation, and that is two ways of measuring it, SaO2 and SpO2. Then we use PaO2. We use a content of oxygen and delivery of oxygen. So can you please elaborate what these terms actually measure?
Yeah, thank you very much for the question, sir. Again, as Dr. Chandrakant sir has mentioned about the basic definitions, this also comes in the respiratory physiology basic definition. It's very important before we discuss something else or other important questions regarding oxygen therapy. So SaO2 is actually the arterial oxygen saturation, sir. And it is, by definition, is the percentage of hemoglobin that is saturated with oxygen in the blood. And we can measure it with the ABG, and as we know that SaO2 and SpO2 go hand in hand, like we can rely clearly on SpO2 also to get the idea about the SaO2. Normally, if we go for the values, it is around 95 to 100% in cases of healthy individual. And if we see the significance, it actually is showing us that how well oxygen is being transported by hemoglobin in the blood. Coming to the another important term, which is PaO2, we use it quite frequently again, and it is actually partial pressure of oxygen in arterial blood. And by definition, it is the pressure of exertion. It is a pressure exerted by dissolved oxygen. So here is the word dissolve, which is important. And in SaO2, when we were talking, we were mentioning about the oxyhemoglobin actually. So this is the dissolved oxygen, which is given the pressure in the arterial blood gas. Again, we can, in the same sitting of ABG analysis, can get the exact value of PaO2. And in healthy individual, the normal values are around 80 to 100 mm of mercury. And PaO2 reflects the effectiveness of oxygen transfer from the lungs to the blood actually. So this PaO2 and SaO2, predominantly we refer them when we are talking about the arterial oxygen status. On the other hand, the two other terms, sir, which you are asking is the CaO2, which is actually the arterial oxygen content. It is the combination, or we can say the total amount of oxygen which is carried out in the blood. And it can be like, roughly we can understand it's the sum of the dissolved and the oxyhemoglobin both. And the normal values, as sir has presented in his slide, that it is around 100 ml of blood will contain 20 ml of oxygen. So CaO2 actually is important when we are talking about tissue hypoxemia. Similarly, the other term is the oxygen delivery, which is also represented as DaO2. And DaO2 is actually the delivery of oxygen to the tissues in per minute. And whenever we are thinking of a patient landing up in the emergency and we find them in hypoxia, our objective or target is to improve the tissue oxygenation. So we need to understand DaO2, and DaO2 is actually the combination of two important things. One is the content of oxygen, which we have discussed just now, that CaO2 multiplied with the cardiac output. So there, when we probably in the discussion later in the day, we will be discussing that not only the lung is the culprit, and there are many other reasons where the oxygen delivery to the tissues can be affected. So the cardiac output multiplied by total content of the oxygen in the blood is the formula for oxygen delivery. And the normal range has also been presented in the slide, which is around 500 to 1 liter ml per minute per meter square, depending upon the body size area. So yes,
very well said, Dr. Ambika. These terms, they tell us a lot about management of these patients in the ICU. Just giving oxygen is not enough to improve tissue oxygen delivery. Hemoglobin is also important. If a patient is anemic, you can give him any amount of oxygen therapy. His total delivery to the tissue will be less. If heart is not functioning properly, the tissue oxygen delivery will be less. So therefore, oxygenation at the tissue level requires not only a management of the lung condition, but also looking at his hemoglobin level and improving cardiac function to get an overall benefit, because ultimate objective is to improve the tissue oxygenation in hypoxia. So Dr. Alisha, going further, Dr. Khusrav had told us about FiO2. Now, FiO2 is a fixed term. Now, does it change? Because when mountaineers, they go up to Mount Everest, although some of them have gone even without oxygen, that is an extreme form of tolerance of lungs, what nature can do. But most of them use oxygen. So why oxygen is required? Does the FiO2 change or something else changes when we go up?
Thank you, sir. So basically, FiO2, the full form would be fraction of the inspired oxygen, right? That is a concentration of oxygen in a gaseous mixture. So around us in the atmosphere, usually it comes up to 21%. Now, the concept is that FiO2 stays the same, whether it is at sea level or a higher altitude. But what changes is the barometric pressure. So at present at sea level where we are right now, the barometric pressure is around probably 760 mm of Hg. Deduct the water vapor from it. And then if you look at the PiO2, which sir had mentioned, partial pressure of oxygen comes up to roughly 150 mm of Hg. But when you look somewhere at Mount Everest, where the barometric pressure comes down almost to 240 to 250 mm of Hg. So even though the FiO2 stays same, but the partial pressure of oxygen comes down to almost 50 to 60 mm of Hg. And that's why mountaineers require oxygen when they go up because of the decreased oxygen levels.
Yes, and some of the mountaineers who have climbed Mount Everest without oxygen, the reason is probably that at the mitochondrial level, the partial pressure of oxygen is only 1 to 2 millimeters. where it is actually used. So even a PO2 of 30 millimeters in the atmosphere, even that provides a sufficient. Of course, that will greatly limit the exercise tolerance. So that is why most of the mountaineers use oxygen. So Dr. Khusrav,
Yes.
since you are doing a double role, you're also a panelist. So, and you may have already talked about this PO2 normal level. We always believe that it is 80 plus, but at even a city like Shimla, where everybody goes as a tourist, it's very popular. The normal PO2 is just 70 millimeters. So that would be hypoxemic by sea level. So how does PaO2 in a normal person change with age and altitude?
Yeah. So basically, so we have spoken of all different types of the O2 physiology. Just like you have saturations, you have a PaO2. So normal would be 90, but up to 60, as you can see the oxygen dissociation curve, there is not much of a drop in the saturation along with the PaO2, because the amount of oxygen which is given off to the tissues remains more or less in the normal range. But after 60 millimeters of mercury, as you rightly pointed out, there's a linear curvature, and there is no S-shaped curve now. There is a linear curve, and therefore the PaO2 and the saturations will not match, and the affinity also will not be good enough, and that would cause tissue hypoxia. So I would say anything from 60 to 90 range is okay, but anything below 60 is definitely dangerous. This PaO2 also depends upon the alveolar pressure, sir. And we have discussed this many times, but alveolar pressure, if it is low, then obviously this would be a high altitude sickness. But if the alveolar pressure is high and the PaO2 is low, that would indicate a shunt fraction or a dead space, like an embolism, etc. So I think we have to put PaO2 as one, not as a number, but as an entire gamut of clinical picture that the patient would have.
Right. So Dr. Nitin, we have already discussed that oxygen is carried in a dissolved form and also as a bound form. What other factors affect oxygen delivery? I know this would be, but let me have your perspective on this. So, other factors which affect oxygen delivery to the tissues.
Yeah, I think one of the most important things which actually drives the whole mechanism is it's always, the heart and the lung work together. So if there is not enough cardiac output, particularly if there is a peripheral vasoconstriction, if there is, for some reason, either a septic shock or whatever the reason would be, if there is a very, very severe peripheral vasoconstriction or organ vasoconstriction, then the delivery to those tissues is going to be affected. The temperature in general will affect it, but a peripheral vasoconstriction will affect it much more severely. I think that is one simple, very, very important correlate of it. And then, of course, I think we already have discussed about hemoglobin amount, concentration of what is happening to the curve. Is it dissociation to the left, dissociation to the right? Is it a carbon monoxide poisoning, so on and so forth? But the most important correlate of a good oxygen delivery to the tissues is going to be a good cardiac output and a stable temperature.
Right. So, Dr. Chandrakant, can hypoxemia occur with normal lungs?
Yes, sir, definitely. As we have discussed, whenever there is a low FiO2, especially at the mountains or height or in the in such places, there can be low FiO2, low partial pressure of this thing, barometric pressure. So we can have the low FiO2 and we can have the less oxygen. Hypoxemia can occur.
Any other mechanism? Normal lung causing
There are
hypoxemia?
different mechanisms, as just explained. There are predominant 4 mechanisms of the hypoxemia. One just not is a low FiO2. Other mechanism of the hypoventilation, especially if there is a decreased alveolar ventilation cases like CNS depression or
Blood poisoning that we get.
severe obesity. In such cases, we can get the hypoventilation. Other mechanism is VQ mismatch. VQ mismatch means mismatch between the alveolar blood reaching to the alveoli and oxygen reaching to the alveoli. If you see the example of COPD, there will be good perfusion, but ventilation will be hampered. If you see the example of pulmonary embolism, there will be good ventilation, but perfusion will be hampered.
Any
These are
ventilation
the example of VQ mismatch. Yes, and the last is this thing shunt. Shunt means there will be means blood will go without any ventilation, means without exchange of the gaseous exchange, such as if there is a VSD is there, or if there is a pulmonary arterial malformation, or even in case of this pulmonary embolism, we can have this shunting.
Right. So let me add a couple of points to what you have told us. One, if there are large true shunts, right to left shunts, they are not responsive to oxygen therapy. So one should not go on pushing oxygen in the hope that one will be able to reverse. Secondly, hypoxemia doesn't always mean that lungs are at fault. And the equation that Dr. Khusrav showed, alveolar gas equation, if the alveolar oxygen difference is normal, that practically means that lungs are normal. So that is a very important distinction, and that is where alveolar oxygen gas equation is a very, very useful equation in critical care medicine. So, Dr. Ambika, how do we recognize?
The classical teaching here is that if there is severe hypoxemia and you have a normal X-ray, think of pulmonary embolism. So that is very classically shown, as Dr. Chandrakant you mentioned. So just for the students, if you have a normal X-ray and you have severe hypoxemia, please think of a pulmonary embolism.
Yeah, but the AO2 will be widened there.
Yes, sir. Definitely widened here.
That will be widened there. So, Dr. Ambika, clinically, as a clinician in the emergency room, without any lab aid, how do we recognize that a patient may be having hypoxemia?
Yeah.
Are there any specific symptoms or signs? Reliable ones.
Yeah. So you have made the question very specific, actually. So when we talk about the hypoxemia, the sign and symptoms can come specific and non-specific also. And it's not that the patient will present only with the respiratory, cardinal symptoms because it is hypoxemia. The symptoms and signs can come from central nervous system. So if we talk about the respiratory symptoms, so patient can complain about with dyspnea, tachypnea, cyanosis when there is severe hypoxemia, which will be bluish discoloration of skin, lips and nail bed. Patient can also complain of chest pain, but not because of the lungs cause, but predominantly because of the coronary ischemia and the cardiac cause. And coming to the other system like cardiovascular system, the patient can have hypotension, sweating, and low blood pressure, and along with that, the common symptoms, which is tachycardia, will be seen. Central nervous system finding is also very important, sir. So sometimes the patients complain of headache. We predominantly think that patient has high carbon dioxide, then it can happen, but it is also present when patients has low oxygen. This patient can feel the dizziness and lightheadedness and can even have the syncopal attack. And along with that, they can have hesitation, confusion, unable to concentrate. So these are altered mental status can be seen with the patients with hypoxemia. Coming to the neuromuscular structures, like patient can have generalized weakness feeling, tremors, a little shaking, want to take the rest, and and can have an imbalance and fall. So there are many symptoms. Specific, if you say dyspnea, tachypnea, cyanosis can be considered as a specific symptoms if we talk about the respiratory symptoms.
Right. So that is the point which you have emphasized, that there's a lot of overlap between the symptom and signs of the primary disease that the patient is having and any symptoms of hypoxemia. So it's a high degree of suspicion that is required, and one has to confirm with the tools which are available in the emergency, like pulse oximetry, and because very specific symptoms of hypoxemia are not there. It's the primary disease that manifests more than that. So high degree of suspicion is required. So Dr. Alisha, when we do a pulse oximetry, what precautions one need to take?
So while using a pulse oximeter, and at least interpreting a pulse oximeter value, then we should be careful there are no motion artifacts, making sure the pulse waveform is good. We should look for any skin discoloration, which could be because of which the waveforms are not being picked properly, especially in low flow, low cardiac output states like shock. Then even the pulse oximetry value should be interpreted very in a caution. And also in cases where there are abnormal hemoglobins in blood, in that case also the pulse oximetry values need to be interpreted carefully.
Yeah, and especially now that you've mentioned the artifacts, nail polish is a very important
Yes.
interfering factor, and we
Yes, sir.
often get misled. So that is very important.
Even jaundice also sometimes
Even
this can
hyperbilirubinemia.
cause
Yeah.
hyperbilirubinemia also
So
can
these are
cause.
important factors which can interfere in our. So any saturation which is less than 91 should definitely go in for an arterial blood gas analysis to confirm the degree of hypoxemia and the type of respiratory failure. So, Dr. Khusrav,
Yes.
you have elaborated very well difference between high flow and low flow. So let me pass this question, or you want to add anything that?
No, sir. If somebody has joined late, I think a low flow is
Just quickly, low. See, the point is very often this impression is there that low flow means low FiO2, high flow means high FiO2.
Yes.
So please clarify this wrong impression.
So we all have an inspiratory flow rate, which is usually 30 to 40 liters. The maximum we can give is 15 liters of oxygen. If this is lower, then the ambient oxygen gets mixed with the FiO2 oxygen delivery system, and therefore the FiO2 will keep fluctuating. So whenever the FiO2 is variable, it is called a low flow system. So again, as sir said, high oxygen concentration or high FiO2 does not decide a low flow versus a high flow. That is a low oxygen and high oxygen. So therefore, nasal cannula, mask, and an NRBM, which actually gives you high oxygen, but is a low flow system. To make the oxygen delivered at the mouth higher than the inspiratory flow rate, there is only one phenomena called Bernoulli, where you pass the oxygen through a small hole, and that gives you a jet stream there. And therefore, that would be a high constant FiO2 high flow system.
So, Dr. Nitin, let's discuss briefly some of the oxygen systems that we use. So first, the nasal cannula and nasal prongs. What are the advantages and disadvantages, and how do we titrate FiO2 using nasal cannula?
Yeah, I think nasal cannula is possibly the simplest, easiest to use. The comfort of using it is very, very good, particularly if you have a good fitting and the irritation is very minimal if you are using a high quality polycarbonate or even maybe a silicone material. So it depends on that. But at the same time, the flow is low. It's typically less than 4 liters per minute, typically 2 liters. 2 liters is what is the bottom line. No, most of the times, everywhere, even include air travel, include home usage, include long-term oxygen therapy, we generally do not exceed more than 2 liters. So 2 liters is a good bottom line that we can take. And if we are using it that kind of a flow and using it as nasal cannula, that is a good enough kind of a augmentation that the patient gets. And so the advantage is ease of use. Connectivity is easy, taking it off it easy. Person is able to drink, eat, do all normal activities. Even he can walk with the nasal cannula if there is a portable oxygen which can come along with him. So I think all those are advantages. The disadvantages, of course, it is whether it is a nasal cannula or whether it is a simple face mask. The problem is lot of ambient air is also going to keep coming in, and therefore there is going to be dilution. So you cannot have FiO2 which is going to be extremely high. I mean, one has to get, we can't expect more than say 30-35 liters, 30-35% more than that. With a typical nasal cannula system, face mask, we can go a little higher, but not more. Partial rebreathing, you can go higher.
And we'll be discussing those.
That I think will come in the next question.
About nasal cannula, the formula that we have been using, and Dr. Khusrav will bear me out, that roughly 1 liter flow gives you 4%.
Yes.
Yeah.
So 24 to 44%, we can go up to 6 liters, we can get roughly about 44. Of course, it's a low flow system. So depending on patient's ventilation, it will vary. Yeah. But up to 44%, we can use nasal cannula.
3 to 4 liters.
And that is, yes, 1 liter, 4% increase in FiO2. That is the rough rule of thumb that we have been using. So, Dr. Chandrakant, then the next step, simple face mask. So, any advantages over nasal cannula and precautions while using a simple face mask?
So when moderate amount of FiO2 is required, for example, if nasal cannula can give up to 40-44%, if you require 40 to 60% FiO2, the face mask is a good option. Other advantage is the patient who is a mouth breather with closed nasal passages. Face mask is easy to apply and we can use in such patients. but it has some drawbacks also. If as Dr. Bajan has explained in the presentation, face mask means we have to keep more than 5 liter. Anything less than 5 liter means we have to, there will be rebreathing and patient can retain the carbon dioxide. There will be no use. Is whenever we are putting the face mask, we need to keep 5 to 10 liter. And approximately, if you keep 5 to 6 liter, it will give around 40% FiO2. If you keep 6 to 7 liter with the face mask, it will give up to around 50% FiO2. If you keep 7 to 8 liter, it will give 60% FiO2. Obviously, other factors matters, such as the capacity of the mask or the patient minute ventilation. There are many factors, but approximately we can give 40 to 60% FiO2 with the face mask.
I think this is a very important fact, that the flow rate, minimum flow rate, because very often nursing staff doesn't know and they may give at 1 or 2 liters, but that will lead to CO2 breathing. And then other disadvantage is that a mask cannot be used with a home concentrator, which usually is up to 5 liters. Very few are up to 10 liters. So this distinction, we need to tell the patients that don't use a simple face mask if you're using oxygen at home. And nurses have to be instructed that do not come below 5 liters when using a face mask. So Dr. Ambika, about a rebreathing mask, partial rebreathing or rebreathing. So how does it work? And are we really using it?
So yes, sir, interesting question, sir. So yeah, so one thing again, I think emphasizing is important that this is a low flow device. It definitely gave high concentration when better than nasal cannula and the face mask, simple face mask, but it is also a low flow variable performance device. And what is different here is that there is a mask which is similar to the Hudson's mask or simple face mask, and along with that there is the attachment which is a reservoir bag. The volume of the reservoir bag is around 600 ml to 1 liter, and there is a connector in between the two, and from there the oxygen goes. So this system doesn't have any wall. Neither the exhalation ports has any wall from the face mask, and there is no wall between the face mask and the reservoir bags. So why it is called rebreathing? Because when the patient exhales the breath, so 1/3 of the breath exhalation volumes goes into the reservoir bag, and luckily with the patients, this volume is an anatomical dead space volume, and patient is given oxygen. That means this is a pure oxygen which is getting collected in the rebreathing mask, partial rebreathing mask. So this is how it works. And but because
it's a short-term measure, because it interferes with patients eating.
Yes, sir. The same. The limitations are similar to the face mask. It is claustrophobic, cannot talk the band, required high oxygen, like 10 to around 6 to 15 liter, and according to the flow, this FiO2 can vary from 40% to 80%, but it doesn't go more than that. And so another interesting thing is that we cannot, be sure how much oxygen is, how much FiO2 is going, because there's so much of rebreathing and the mixing. Yeah. So with this, there is a mixing of inhalation from the side ports also. So yes, this is a variable performance winner. But I wonder that in like today's era, it nearly replaced by the non-rebreathing mask, and it doesn't fit to any specific indication. I don't know. I have heard some of my colleagues, they use for the patient of hyperventilation without giving the, but it's not.
Maybe in peripheral centers where the resources are limited, they just attach a bag to the simple face mask and make a partial rebreathing mask. So Dr. Alisha, more often we use a non-rebreathing mask, especially in COVID epidemic, it was used a lot. So Dr. Alisha, what are the applications, how we use it? Where would you use a non-rebreathing mask?
So ma'am has actually made my job easier. She told partial rebreathing mask. My thing is just non-rebreathing mask. That means there's a valve now between the mask and the reservoir bag. And the same thing, it's a low flow variable performance device. So we are not sure about how much the FiO2 is going to go through, though it can actually achieve up to 0.8 to 0.9. So the good parts about it, that in cases of acute hypoxemia, making sure there is no type 2 respiratory failure, just plain acute hypoxemia or carbon monoxide poisonings where you really need high concentrations of oxygen, this is a very good thing to initially start with. But the only issues is that even the oxygen concentrations can vary, especially if somebody with higher inspiratory flow rates or high minute ventilation, we need to be careful. And the other thing is you have to always make sure that there's a tight seal with the face mask on the face so that your adequate FiO2 gets delivered. And especially that reservoir bag should not be emptied more than 1/3 during the inspiration. So these are some things we should remember while using an NRBM, but definitely a good thing, at least when you initially want to give a higher FiO2 to a patient.
And if a patient has a nasogastric tube, again, that becomes difficult to have a tight fit with the mask. So, Dr. Khusrav, you explained venturi system very well. So, I have one question. Now, the adapters, they come with the flow rate written and the FiO2 written. So, are there any circumstances where we would need to increase the flow rate beyond what is written on the adapter?
Not to my knowledge, sir. 10 years ago, if you would have asked me this question, I even knew the color coding. But now I cannot depend on my memory because I'm getting old. So we look at the flow rate that they have written. And as you rightly said, 1 liter would be about 3 to 4 FiO2 difference. And therefore, whatever flow rates they write depends upon the hole and the side ports. So if you actually see them, forget the colors, but the lower FiO2 one will have a smaller hole and a smaller side port than a FiO2 which is actually higher. So I think I'm confused. So the ones which have a higher FiO2 have a smaller hole and a smaller side port. So that's what I know about venturi masks. But they have given us an arbitrary figure, sir. And if the saturations are not good, then you might have to change the venturi mask to actually what they have written. So this is time tested. So I would not go beyond the manufacturing advice, but I would love to know from the panelists if there is a better answer.
Because what I have read, and especially if the patient is tachypnic, then you may need to increase the flow rate of 50% higher than what is specified on the adapter.
Yeah, sure.
The tachypnea beyond 30 per minute.
Okay.
We almost at 10 o'clock and there would be questions from the audience. So I'll just skip some of the questions which Dr. Khusrav has very well taken. So to avoid repetition, Dr. Nitin, I'm skipping one question, coming to the next question. Besides oxygen, like what other management modalities will be required to improve oxygen in an ICU?
I think, yes, that's a very, very important question because I think in the ICU settings, very often, one of the important ones in the COVID times we learned is proning, because just changing the position, because somebody lying flat for a long time, proning makes a big difference. Increasing the cardiac output by changing the blood pressure favorably without causing vasoconstriction. So if I'm using pure NORAD, it's not going to be as good. But if I'm using something like a vasodilator, like Dobita, in a given situation, not very, I think there are very few indications left for IV dobutamine. We used to use it a lot in the younger years, but I think that, but if there is a vasodilator which can make things better, that is another. If there is a bronchoconstriction coexistent and I'm using an adequate nebulization, that is going to improve my delivery to the peripheral areas. If I have a small airway obstruction and I am using an appropriate molecule which is reaching to the small airways, it is going to make a difference. For example, small particle beclomethasone. So I think in a nutshell, there are a number of things which we can do. I don't think we can be exhaustive about it, but I think there are more than what just meets the eye of just delivering more oxygen.
Yeah, besides what we have already discussed, like building up the patient's hemoglobin, improving cardiac output, and airway clearance to improve the ventilation of the patient. So, Dr. Chandrakant, we have discussed high flow nasal oxygen, and it is one thing which is gradually eating into the space of NIV. So how do these two modalities compare at present for type 1 failure? Type 1 failure.
HFNC is a very good modality, and recent studies, especially mechanism-wise, it creates some positive nasopharyngeal pressure, and it increases the PEEP. Even in adults, the studies show that PEEP up to 7 can be generated, and even in children, it can be even up to more PEEP can be generated with the use of HFNC. And the patient who requires more oxygen and who are on the verge of requiring NIV or a ventilator, we can try the HFNC, especially if there is no type 2 respiratory failure. And there are evidence also, even a 2021 Cochrane review, it showed that There's little or no significant difference in the treatment failure when compared with the NIV or non-invasive positive pressure ventilation. And even in 2023, also there is some meta-analysis. They studied almost 18 studies, and out of that, most of the were the COVID studies, COVID patient studies, or COVID patients, and it was HFNC was comparable to the NIV in most of the studies, and that's the reason HFNC can replace NIV in selected cases of the hypoxemic respiratory failure.
Yeah, one issue with an HFNO is that it uses a lot of oxygen.
Yes, sir.
That is one limitation, and especially in COVID times when oxygen was scarce. So that issue did come up when we had limited supplies. So our hospital management did ask us to be a little careful on that. So Dr. Ambika.
Nitin has a point, I think. Nitin wants
to. Dr. Nitin, please quickly.
Just emphasizing what has been said. In fact, high flow nasal cannulae use a huge amount of oxygen, and as you go to the peripheries, as you go more peripherally, there is a big problem about using HFNO. HFNO in my unit, we have used 17, 18 HFNO during the COVID time and the same amount of non-invasive ventilators. So we were having some on a given day, maybe 40, 45 ventilators working. So 10 or 12 of them were invasive, 1 or 2 would be ECMOs, and 17 or 18 would be either HFNO or NIV. That kind of a luxury is only possible when you have a liquid oxygen supply in huge amounts continuously available to you.
Yeah. So that is a limitation.
The more you move to the periphery, there are problems, and therefore people have to be little judicious. I'm not saying they have to be conservative or supra-conservative, but they have to be little judicious when they are choosing HFNO over NIV. NIV may be a little bit better there, little bit. I'm not saying it can't completely replace HFNO. When HFNO is genuinely indicated, it's indicated.
So, Dr. Ambika, if you have to write a prescription, a practical part in an ICU patient, so how would you write a prescription for oxygen? A patient of COPD, let us say.
Yeah. So again, coming to your first line, then oxygen is a drug, and we need to prescribe it, whether we are giving it for the LTOT at home or whether we are writing it in ICU. So 4-5 things we need to write it very clearly. When one is what delivery device we are going to use, like is it the nasal cannula, venturi, or rebreathing, or HFNC. Second, the flow rate, what flow rate we are giving, or if the patient is on NIV or HFNC, we can fix the FiO2. Third is how much duration of treatment when we are we going to need to write what is our target saturation, because in case of COPD we keep the low target at 88 to 92%. So that is the fourth one, and flow rate I have mentioned, and oxygen delivery. So if you ask me to write it, I would write it that oxygen inhalation via nasal prong. I'm giving an example at the rate of 1 to 2 liters per minute. To achieve the target of 88 to 92% and to be given for 14 to 17 hours or continuously when the patient is in the ICU. So this is how it need to be written, and there need to be a special so remarks also we can put. If the patient is in ICU, we can even explain our nurse that we are weaning this patient and gradually taper off the oxygen when the target oxygen is. So weaning protocol and a humidification details should also be mentioned when we are writing a prescription for the oxygen.
Thank you. And Dr. Alisha, now that Dr. Ambika has put the patient on oxygen, so how will we monitor the patient? Like in many ICUs, we have a protocol of daily ABG analysis. Is a VBG analysis useful?
So first part of the question, that monitoring of oxygen therapy in ICU, it can be done both in a non-invasive and invasive manner. Non-invasively will be first looking at the clinical condition of the patient. How is he, like, has the irritability and the restlessness come down, tachycardia?
Just the objective measures.
And then apart from that, we'll be also looking at the pulse oximetry. The target saturation would have been mentioned, whether it is being maintained. And then other things for resource limited settings we're also mentioning. So SpO2 by FiO2 ratios we can look at. And in patients who are on HFNC, we can look at the ROX index, SpO2 by FiO2 over respiratory rate. Coming to invasive means we have the arterial blood gas, which is most commonly used, where we can look at the PO2 FiO2 ratio. There are other indices even available, especially for patients who are on ventilators, something called as oxygenation index also. There are many things available, but most commonly
Routinely, in your routine, how do you do it?
routinely would be with
Do
pulse
a daily
oximetry and
ABG?
lateral, not a daily ABG, at least maybe, once in at least 12 hours to just see how the patient has responded to the oxygen therapy.
So once one gets a fair idea of the patient's requirements, even a simple pulse oximetry is good enough to monitor the patient along with the clinical. What about VBG? Sometimes you get a venous sample. Do you discard that sample or still try to make sense out of it?
Actually, venous blood would be very much, would be used for ventilation, at least for pH and the PCO2 part. But for oxygenation purpose, definitely not the gold standard. But definitely there is evidence right now that coming up that even VBG can be tried. At least we can look at the oxygen saturation in VBG. If that is something more than 75%, almost it nears the arterial blood gas sample. That is what the current theory is, and something
that is a very important point. Sometimes nurses or residents take a sample and it's a venous sample and they would just discard it. That should not be done because it has useful information in this, and you just pair it with the pulse oximetry reading and you have a fair idea of how the patient is doing. So they were questions
on
on
a point here, very quick point. Yeah.
Yes.
So nowadays for shock index also they're looking at the carbon dioxide difference between the arterial and venous, and even the oxygen difference between arterial and venous. So venous is coming up in a big way. The problem is when you get a low oxygen on the so-called ABG, how do you differentiate ABG from VBG? So always remember one thing, that you can, if the CO2 is more than 45, it can still be a VBG or an ABG.
Yes.
But if the CO2 is less than 45, which can never happen on the venous side, then you are sure that it is a arterial sample too. So CO2 will tell you whether it's a VBG or ABG, because that's a dilemma. No, I collected it properly, so it can't be a VBG. But if the CO2 is less than 45, then more likely it is an arterial. But if it is more than 45, it still could be a venous.
So let's see what our audience wants to discuss. So I'm just going to open up that chat box here. And so we'll start with Dr. Khusrav. There's a question from Dr. Tridib Chatterjee from Mumbai. Oxymask versus HFNO, which would be better in terms of effectiveness, cost, availability?
No, you can't compare the two systems. HFNO is super oxygen. You need a lot of oxygen there. Oxymask can be probably compared to the entire spectrum of nasal cannula, mask, venturi, and even your non-rebreathing, because it can give you oxygen concentration between 24 and 90%. And it doesn't need a tight-fitting mask. Whereas HFNO is an expensive technology. It uses not only money, but it also uses a lot of oxygen, as we discussed, and you need very high flows there. So that automatically by the machine delivers high flow. But when we talk about venturi mask, it delivers it through the Bernoulli phenomena. So we're talking of different things and we cannot compare them.
The resources required for HFNO are far much more than for an oxymask.
Yes, sir.
Oxymask is the one thing which can be used in periphery also.
Periphery.
Dr. Nitin, although we have not been discussing air travel, but there is a question. So briefly, how would oxygen therapy be managed during air travel? Because that's a separate topic in itself. So I deliberately left it out. But just a brief answer to this question, Dr. Nitin. Oxygen therapy during air travel.
Yeah, I think one of the brief things is, if somebody is on oxygen already, very simply, somebody is using less than 4 liters, he is recommended to travel on around 2 liters. Because your cabin pressurization is at 8,000 liters per minute, and you generally can't deliver 4 liters throughout, say, for 18-hour travel to New York. So that is unrealistic. So you have to to compensate between the need and this. You have to remain sedentary. You should not be running around. Obviously, nobody runs around in air travel. But at the same time, minimize your activities. That's the first. If you are trying to evaluate somebody less than 93% should be, you start evaluating. the first test that you do is do a 6-minute walk test. If the 6-minute walk test shows desaturation less than 85%, then you go through a what is called as HAST, and one of the mechanisms by which we can assess people. And if they are showing that, look, this is going to be a high risk travel, then they will be recommended depending on what their decompensation is. Generally, one way or the other, you come down to 2 liters. So whatever it is, you don't give more than 2 liters. If somebody is requiring more than 2 liters continuously, then he better not ever travel. You just simply say no.
So, Dr. Chandrakant, we left out home oxygen therapy, but there is a question. So, what are the important considerations when providing long-term oxygen therapy at home? I don't know what our person wants considerations, but Dr. Chandrakant, that's just the indications. When would you prescribe and how many hours per day?
Yes, sir. Any patient with a chronic respiratory failure because of either COPD or ILD, whatever the pulmonary hypertension, if the PaO2 is less than 55, then it's indication for the long-term home oxygen therapy. And in some cases, even if the PaO2 between 55 to 60 and associated with the polycythemia, edema, or if there is a evidence of pulmonary hypertension, core pulmonary, we can consider for the, and even there is a risk of arrhythmia, we can consider the LTOT. The deadline is this PaO2 less than 55 in the APG, not the saturation. Because saturation can vary with if the finger is cold, if the patient is having some scleroderma, many factors will be and bring the saturation. That's why PaO2 we have to check with the APG. And patient who get discharged, immediately we advise for some oxygen therapy if the PaO2 is less. But we have to recheck after 8 weeks to level as a long-term oxygen therapy. If after 8 weeks also, if the PaO2 is less than 55, we can give the long-term oxygen therapy. And benefits are, it improves, as you know, hypoxia is the main reason for the pulmonary vasoconstriction and pulmonary hypertension, which leads to the core pulmonary and the respiratory failure. So if you give the home oxygen therapy to such chronic respiratory failure patient, it improves the pulmonary, it reduces the pulmonary artery pressures and prevents the progression of the pulmonary hypertension and core pulmonary respiratory failure. And clinical benefits means it improves the exercise tolerance, improves the quality of life, and even in COPD cases, it improves the survival also.
So it should be used when indicated. What about specific instances like only nocturnal hypoxemia and normal daytime saturation?
Nocturnal hypoxemia, those
patients. Is there evidence in that?
The evidence-wise, as such, patient who desaturate during night, especially more than 30% of the time.
Non-apneic desaturation.
Non-apneic, yes, sir. They can develop the hypoxic pulmonary hypertension. In such patient, there is a benefit, but routinely it should not be advised for every patient.
Yeah. So that is a gray area.
Sir, can I come in just a minute in this? Obesity hypoventilation has that classic subset where during night they tend to be very, very severely hypoxic, and using a BiPAP ventilation at that point in time, because they are hypoventilating rather than really truly hypoxic. So using a BiPAP in the night might be a better idea than just using oxygen blindly.
For patients with obesity hypoventilation, definitely a BiPAP is a better support than giving only oxygen to these patients. So, Dr. Ambika, question here is, how is oxygen toxicity managed once it occurs?
Okay, so as sir has mentioned in his presentation, prevention is better than cure, and there are many possibility, different types.
It's very difficult to recognize oxygen toxicity clinically.
So like when a patient of COPD is there and when we are giving it, we know that the oxygen was going all full all night, and the morning the patient who presented to us and is admitted in hospital with the PaCO2 of 55, and in the morning we are finding it somewhere 80, then we can get an idea that this is the oxygen which is got the toxicity to this patient. Similarly, sir, as oxygen toxicity can cause atelectasis or absorptive atelectasis and decrease in PaO2. So one should keep that mind, like what complication is there. It can even, as sir mentioned, that it can even lead to the ARDS. So management will be specific to the what toxicity we are talking about. So one, it will be the, again, coming back to the judicial use of oxygen that we need to do, and whatever the toxicity we are facing, if the carbon dioxide has increased, then we need to go for the bi-level of positive airway pressures support, and when if there is ARDS, then probably we are increasing oxygen to combat that part of the
basically
ARDS.
symptomatic and supportive treatment, because nothing specific antidote is available for that. Antioxidants people use, but no evidence that they are going to help.
And stop the oxygen as far as possible. Don't give too much oxygen.
Yeah. In fact, I was looking at your last few slides. The whole idea that low or less is better, that is very much there in physiology. If you look at the oxygen dissociation curve, there was never any reason to give high flow.
Yes, sir.
If you understand the plateau of the oxygen curve, this thing is established for decades.
Yes.
So these results are very much predictable, that low is better.
Absolutely.
High is never going to help, because you don't need to go to supra-oxygen levels. Saturation of 90 plus is good enough.
Absolutely.
So going further to more questions, a lot of questions on oxygen toxicity.
Very difficult to diagnose that.
Yeah, Dr. Khusrav, another question. What is hyperbaric oxygen therapy? You have already, maybe the person joined in late. So quickly, if you can just...
It's not really part of the preview of oxygen delivery, but we'll just talk about it. Hyperbaric oxygen is given in a chamber. It is usually 2 to 3 atmospheres. When 1 atmosphere is 760 millimeters barometric, anything above 2, preferably 3 atmospheres, is called as hyperbaric. This gives you so much oxygen that you do not depend upon your hemoglobin affinity with oxygen, and this will deliver 60 mils per liter of oxygen to the tissues when you don't need any of the oxygen reserves that you have in the body. So by and large, it is only proven to be beneficial in carbon monoxide poisoning and sometimes in necrotizing facial.
And you would require resources for that. It's a special tent is required. It improves the dissolved oxygen. Normal dissolved is 3 ml per liter.
Yes,
but with hyperbaric, you increase the dissolved oxygen. So that is probably when the hemoglobin is not able to carry the oxygen, then it's useful. So Dr. Chandrakant, Dr. Nitin, role of oxygen therapy in pneumothorax patients, very routine question, but since somebody has asked.
Absolutely. I think it's a textbook question, but I think if it is a mild pneumothorax, it's not going to cause, it doesn't require a drainage according to the guidelines, and you give oxygen, it is likely to resolve faster. So if it was going to resolve in 15 days, it will probably resolve in 7 or 8 days. So giving a low flow oxygen is a good idea in that situation, no problem.
But in most of the cases of iatrogenic pneumothorax, it resolves by giving such therapies. And most of this iatrogenic pneumothorax doesn't require this ICD. And basic mechanism for the, I think, understanding the person who has the question. Basically, if you give the oxygen, it will replace the nitrogen in the air. And oxygen will get absorbed faster. And that is a mechanism which resolves the pneumothorax.
The only thing is that either the patient has to arrange oxygen at home or stay in the hospital. Choice.
Either way, it is expensive.
Sir, I personally, I don't believe in this theory of denitrogenation. I completely feel that, I'm disagreeing with all the panelists here, but how can oxygen actually reach the tissue level and reduce the pneumothorax? So I know we do it as practice, but denitrogenation is probably a myth. And a small pneumothorax which does not need ICD is going to resolve by itself. A spontaneous one, primary one may resolve. So I have my doubts about giving oxygen for a pneumothorax.
Actually, denitrogenation can occur only when you completely replace nitrogen in the inspired air.
So
100% oxygen, only that can do it.
Yes, sir.
Khusrav, one way or the other, we see so many pneumothoraxes and so many of them refuse an ICD that we actually we have, you can say, in our mind, a controlled case scenarios where they say, I have given oxygen, I have not given oxygen.
Yeah.
When I have given oxygen, it heals better.
Okay. Yeah. Maybe.
Dr. Alisha? Yes, Ambika, you want to say something?
Yes. So for the same situation, one more confusion stays among the residents that like guidelines, they write high flow oxygen should be given to the patient. And the principle is to give replacing the nitrogen from there. So 100% oxygen can be given through the low flow system, which is a reservoir system. So I want to ask if both are equally good, one can use a reservoir bag or this. So many of the residents, they always get confused and they come with the line written in the guideline that high flow oxygen. That means we are using Venturi in this case.
Objective is to use a high FiO2, whether you deliver it through a non-rebreathing mask or a Venturi system. But the point is the patient has to stay in the hospital, and a non-rebreathing mask to use for days together is almost impossible for the patient.
And so made a very important point. Full nitrogen has to be replaced by oxygen. The full denitrogenation has to happen. So I don't think in clinical practice that really happens. But I stand corrected if the experience also mentions that.
Oh,
but these are protocols, and I suppose
it makes sense. In people who are not, see, in any case, we are not talking of people who are accepting an ICD. We are talking about people who even sometimes deserve an ICD and not accepting an ICD. Even in those patients, it tends to heal faster when you use
But these are protocols, and definitely, in these days of litigation, one should always advise the right thing, whether the patient agrees to stay in the hospital or not. That is very important.
Whatever he accepts that's his choice.
Dr. Alisha, will come to you now. There's a question. When do you use oxygen intermittently? Not long-term, intermittent oxygen at home.
At home.
In practical, your experience, where you would have used?
Only intermittent oxygen.
Intermittent. SOS basis. I'll tell you, this is relevant because you get these small cylinders in the market now. They are cylinders which you take just puffs of oxygen. Even that thing is available now.
So sir,
inhaler of oxygen.
Typical scenario which comes to my mind is, hypersensitivity pneumonia or an ILD, which is hypoxic only after exercise. And within 15 minutes, he returns back to normal. I think that's a classical indication for using intermittent oxygen, where you just tide over the crisis. For example, somebody is unable to take a bath because of the work which is involved, and he's able to comfortably able to take the bath because he uses it for half an hour, and then maybe another half an hour after it, and he's off it. And that is the early ILD, where the desaturation is not constant and permanent, but only intermittent. You can use intermittent oxygen. It is allowed.
For some ILD patient, even those who are not fitting into the criteria of LTOT, but if they are so much breathless, they may damage from the oxygen therapy. This is one of the
important indication. It's an important point that you are raising, that oxygen as a therapy for dyspnea, even when the patient is not hypoxemic, because some patients do find, whether it's a psychological thing or no, but they do get benefit. And in advanced lung disease, symptomatic treatment would include intermittent use of oxygen also, because in those patients, we are not attempting to increase survival of the patient or improve his long-term pulmonary hypertension. The patient is severely crippled, dyspneic, and if he gets better with oxygen, there's on humanitarian ground also we can prescribe that, let him take intermittent oxygen. Now let's see more questions. Dose and duration of Diamox at high altitude in sensitive patients. Any volunteers from the panelists? I don't know whose area this is. Dose and duration of Diamox. Why would Diamox be used at high altitude?
Sir, it has been traditionally used and abused.
Yes.
And everybody who travels carries
their tablets.
I don't know whether it is.
Many of the patients
in high altitude cerebral edema, I think only in those cases it has been tried, but I'm not sure as a part of regular protocol whether you.
As a start, in fact, hypoxia, when it is there and you correct it with either oxygenation or climbing down a certain 1,000 feet, whatever that is.
Yeah.
Either ways, you have to re-stabilize the oxygenation. That is the correct therapy, rather than just popping up Diamox and climbing further.
So acetazolamide is used mainly for prevention, but it's not got much of a role. Pulmonary alveolar hemorrhage to be prevented with steroids. And the drug we never talk about for high altitude is clonidine. So actually a calcium blocker is more useful to prevent high altitude sickness than any of these.
Now there's a question from neurologist Dr. Ramajan. which I have read for the first time. Using oxygen therapy in cluster headache is very useful.
Yes, actually, NRBM, one of the indication is useful in cluster headaches, actually.
Cluster headaches. Okay, so possibly causes
cerebral
vasoconstriction.
It relieves.
Because headache would be related to vasodilatation, cerebral vasodilatation.
Yeah, but that's what it's written as one of the uses in NRBM also.
Okay, so we have learned something new today.
Interesting.
Dr. Nitin, type 2 failure, which is better, continuous low oxygen or intermittent oxygen?
Continuous low oxygen is better, no doubt. But of course, if I have to, if I'm clearly getting a signal that the CO2 is continuously climbing, then I'll combine it with a bilevel ventilation or BiPAP ventilation, whichever is appropriate.
Yeah.
Only one question, sir, in the panel. I think somebody has asked over here. I was just seeing about the HFNC. How do you know how much I think about the PEEP or something? How do you calculate the PEEP or something?
PEEP in HFNC, you cannot. It's roughly about 5 to 7 mm during expiration that you get. Higher the flow rate, higher will be the PEEP. But that is the limit.
It's a little above the physiological PEEP, but which will be 5 max. So maybe 7 or 8 at the most, but not more than that.
Not more than 5 or 6. And it's a presumption. It cannot be calculated.
Tough calculation.
So even there is a question regarding the current guidelines for LTOT in COPD and ILD.
That Dr. Chandrakant had covered. So,
very well.
So that is why I didn't go back. Because home oxygen therapy is, an area where the evidence is of the 80s. Those trials have not been repeated, and they are 15 to 18 hours trials. The not trial,
the minimum is 15 to 18 hours.
15 to, and there are no study for, and we have extrapolated that information from COPD to ILD, to bronchiectasis, to any kind of chronic hypoxia.
Yes.
We'll hope that we are going to prevent pulmonary hypertension in these patients. In fact, that is the only treatment we have for group 3 pulmonary hypertension in these patients. All other drugs have failed in group 3 pulmonary hypertension, except for oxygen therapy.
What about prostacyclins and nitric oxide? I know they are not available, but...
Prostacyclin analog, there was a recent study, that's a perfect study, so that failed.
Inhaled one may come in a year.
That failed. There was a recent report on iloprost in COPD pulmonary hypertension that has been stopped because of the side effects. Negative studies there. So, quick question about the systems for home use. When do we use high flow concentrator? There are concentrators which are available up to 10 liters also. Most of the patients use 5 liters. So, Dr. Khusrav, your turn first.
Sir, I'm not good with home oxygen. My expertise would be ICU, but I think you can have an oxygen cylinder, but if you're using 4 and 5 liters, you'll have to keep changing it very often. So oxygen concentrators are the way to go. And COVID taught us exactly about oxygen concentrators. People were hoarding them and buying them for 5 and 10,000 and keeping them at home. So oxygen concentrators are definitely an easier way and a more comfortable way of delivering high level of oxygen. But if you need 1 or 2 liters, then you can calculate and you can get big cylinders, etc. But
Dr. Nitin, portable systems for home use.
In fact, a lot of my patients today are actually using portable oxygen concentrators also. They are traveling the globetrotters, in fact, and they are taking it to the airport. They have access to the oxygen in the flights. So I think oxygen has, increased its overall expanse in oxygen usage in chronic patients who are chronically hypoxic. Generally, I would reserve it to low flow requirements. So less than 5 is most of the times adequate. But somebody who is requiring a BiPAP ventilation, then I'm not that worried about the CO2 retention which is caused by high flow. So even if he requires 6 or 7 or 8 liters, and I will give it. More importantly, I think what is realistic is when we do one-to-one testing in the oxygen concentrator vis-a-vis a hospital use oxygen supply, it matches. It's usually 50%. So if I say 2 liters prescribed on oxygen concentrator, it amounts to 1 liter in the hospital.
Very valid point. Yeah.
Right. So
Yeah.
I think
And
we have
that
had a very
also
good
In
discussion.
the airlines, in the aircraft, they prefer using concentrators and don't allow any oxygen cylinders because they could be flammable. So therefore, concentrators are preferably used even in flights.
So we
absolutely.
have had a very good, and these are allowed to be taken in the flights also.
Yes, sir.
So we have had a very good discussion, and I think we have covered all aspects coming from starting from the brilliant presentation from Dr. Khusrav and then questions and input from all the panelists. So a final round of quick one-liner advice for patients or residents on oxygen therapy. Dr. Khusrav,
So
a quick
oxygen is a
message to
drug
your
and use it
residents.
carefully. Yeah. Oxygen is a drug and use it carefully and judiciously. And we may end with Nitin singing a poem on oxygen.
Dr. Nitin, poem maybe some other time, but your
Not a
background is
poem.
very good.
Not a poem, but I'll quote the quote which is reversed to Khushrav's, that most of the damage in COPD is caused by it's caused despite using oxygen rather than because of oxygen. So in fact, all the damage that was caused by long-term COPD damage was because of hypoxia rather than excessive oxygen. So I think that's that kind of a message. Of course,
See,
we have to
long term, I agree, Nitin,
when
but
it is
I was
relevant.
talking about ICU. Yeah.
ICU.
Dr.
Yes.
Chandrakant,
These are different
message
scenarios.
for your residents and nursing staff on oxygen therapy.
Use oxygen judiciously, and for every breathlessness, treatment is not the oxygen. We need to use it whenever it's required, absolutely indicated, then only we should use the oxygen. And most important is the monitoring. Just don't start on 3 liter, 4 liter, and just leave like that. Always, time to time, we need to monitor, we need to adjust it. That is the most important.
So, Dr. Ambika, first thing tomorrow that you will do is first you will tell them how to write a prescription.
Yeah.
Things you
About
will tell them.
that only ki oxygen start kar do. I'm not going to say that way, and I'm not going to say my resident to speak in that way. So one need to be very specific while writing the oxygen prescription, and all detail need to be mentioned, special 4-5 points which we have mentioned.
And the role of the paramedical staff, the nursing staff, and the respiratory therapists is very important in oxygen monitoring.
Yes.
Everything cannot be left. So they also have to be part of the team. Right?
Yes.
Dr. Alisha, any message to your residents and
Be
paramedical
good
staff?
friends with your pulse oximeter, which can be a very, very useful tool, I think, in your critical care unit or your ward or emergency care to monitor your oxygen therapy. Most easily available everywhere, periphery or tertiary centers where we are working in. So acknowledge it and properly interpret it, I hope.
There are two of my students are here on the panel, Chandrakant and Ambika, and they will certify that I always tell my patients that there are 5 vital signs in pulmonology, and pulse oximetry is the 5th vital sign.
Yes, absolutely.
One must carry this in your pocket. You have to use it even if you're not using a stethoscope. And nobody now examines the patients that way, but pulse oximetry is vital. So, wonderful evening.
Sir, if I may say one last liner. You were talking about a poem, so I'll just end it with one liner.
Ishad.
Yeah.
सांसों की जरूरत है जैसे सांसों की जरूरत है जैसे जिंदगी के लिए बस एक अच्छा डॉक्टर चाहिए प्रिस्क्राइब करने के लिए.
अरे वाह.
That I think sums up our discussion. So I would like to thank our speaker, Dr. Khusrav. Learned a lot from you. Thank you very much, and hope to keep interacting with you in future. Dr. Nitin, needless to say, you are one of the best in the field, and your pearls of wisdom are always welcome and a treat to listen to. Dr. Chandrakant is growing in the field, and we shall be hearing more from him as time goes by. Already a well-established pulmonologist, and I thank him for his contributions. Dr. Ambika, really nice to have you with us. And your inputs were very valuable. It was great insight. And Dr. Alisha, thank you very much for being with us. You really provided great inputs both for the residents and for the paramedical staff. Dr. Naina hasn't joined, so I would like to thank her in absentia for organizing this seminar on a very wonderful topic. And in education, nothing is a waste of time. And oxygen therapy, we started with saying that it's a drug. It must be used as a drug, and one must learn the basics starting of physiology and understand that technology that's behind the different systems and use it judiciously. And I would like to thank the sponsors for making it possible to have this wonderful session and all the resources that were put in this. So with that, I thank...
Sir, on behalf of all the panelists and all the delegates, we must thank you, sir, for giving a prelude, giving an amazing moderation and a climatic kind of to the entire discussion, and really
kept
hats
us on
off.
our toes.
We are honored to be with you, sir, on the dais. Yeah.
Thank you. So,
Questions were
time for
excellent, sir,
dinner.
for the PGs and
Unfortunately,
everyone.
we cannot have a dinner together, but
We will.
leave for that. Okay, so good night, everyone.
1780 logins. Huh? Yeah, the last login count is 1780. This is
So
highest.
success by all means.
Great.
Thank you very much and good night.
Thank you. Thank you, everyone. Stay safe.
Good night, sir.